Good morning. I'm Rafi Neiman, and you are tuned into week 6 of our AO Osteotomy weekly course. We're going to have a group of faculty here today that will help you discuss several cases. Should be a lively discussion in several discussion groups. Today's topic is femur diaphysis. We went through the previous week, Saturday and Thursday last week, going over the concepts. Here's how this is going to work today. For about the first 15 minutes, I'm going to go over a case that will be of interest to all of us related to the femur diaphysis, and then we'll go into breakout rooms, and there'll be several breakout rooms. The participants will automatically be divided up into those rooms, so you won't have to do anything to get into those rooms, as will the faculty. They'll be sent into these rooms, and in those rooms, you'll have basically 70 minutes to discuss these cases, and you'll have the ability to send in questions, and if you choose to talk, you can also ask questions and join the actual discussion. After that time, you'll be brought back into the main room, where I will do a quick summary and wrap up, and give you information for subsequent sessions. It should be known that this is recorded, so it can be archived, and you can refer to it later. This will be of tremendous benefit to all of us as a freestanding osteotomy course. But if you do not want to be part of this recording, then make sure that when you're in your discussion groups, you leave your camera turned off and your microphone muted at all times. And really, that's going to be necessary for all of us that aren't talking to turn off your video and audio unless you're actually going to be talking. The information in here will be copyrighted as well. So make sure your microphones are off. When we're in the sessions, you may have the ability to use Q&A or chat, and when we're in the small groups, you actually could use chat. The femur diaphysis learning objectives that we covered over the past week, we're going to reinforce them here with these cases, and the objectives are going to be to learn and understand the femoral diaphysis deformity correction and non-union management, using these techniques to restore extra-articular alignment, and recognize strategies for leg length and bone transport. So with that, I'm going to start on a warm-up case for us. This will be to get everybody involved. We have a lot of faculty here today, so I'm hoping to hear from several of them. This case is submitted by one of our faculty. Mauricio Kafuri did at least half of this case, and then his partner colleague did the additional portions of it, but it illustrates a lot of good points. This is a woman who's 24 years old with hypophosphatemic rickets, and her main complaint is bilateral knee pain. And you can see that she's got quite a bit of bowing and torsional deformities. She has had attempts in the past at epiphysiodesis. That was 13 years ago when she was still growing, of course, and she's short-statured. This is what her clinical appearance is at the time that Mauricio saw her, and her gait. So clearly some not just angular deformities, but torsional as well. And a standing radiograph with some mechanical axes that I drew in there for you. So it would be a bit overwhelming to try to tackle all this at one time, although you do need to keep every part of this in mind because the entire lower extremity is deformed on both sides. So each action is going to have a consequence in the remainder. But let's try to look at this one one piece at a time. And that's actually how Mauricio did this too. So you see a femur with a coronal plane deformity, which is moderate, and then quite a bit more deformity in the sagittal plane. I can't tell you why he got the CT scan that he did. We've had discussion over the last week about when it's indicated to get CTs for these extra-articular deformities. But he has it. I suspect that the reason is for the torsional deformities, because really you need to understand that when you're going for complete correction. So what are the assessments here? What are the problems that she has? She obviously came in with knee pain. And then she's got these angular and rotational deformities. So starting with the right femur, I'm going to ask our panel to give us some thoughts about what we have and what our options are for tackling this. And maybe is Mike Miranda available this morning? I see he's here.
Yes, I'm here.
So Mike, when you see this deformity, what are you thinking as far as options, and what are you thinking as far as additional workup?
So I think, making sure that you get satisfactory radiographs, your standing films, as we talked about in the first week. There we go. As we started in the first week, it was important to make sure that we got proper radiographs. So I'd want to make sure I understood what her true deformity was, so that would be the workup as far as the plane radiograph, CT scan to determine the rotation, and that would be helpful for the pre-op plan. With regard to the absolute correction, I think that I would be thinking of fixing this with a nail after having done a clamshell osteotomy. I think that sort of cuts to the chase, and I'd be interested in hearing, other folks talk about their other options. But that's at least what I would think about.
Yeah. So we're going to assume that her previous hypophosphatemic rickets has been addressed, and she's metabolically normal. Sean, you're going to be talking about some other options for osteotomy in the coming weeks. Besides the clamshell, are there other things that you think we could do for this deformity? Just Sean, just describe the deformity a little bit as far as how much of the femur it encompasses, and then what that allows you or does not allow you to do.
Yeah, so I think part of the problem with this is because it's a long femoral bow. There are multiple sites of deformity. So when we're going to talk about single cuts for correction of deformity, that assumes that you have one cora, a single deformity without translation. And while this one doesn't have translation, I think if you were to draw this out, you could not distill this down to a single deformity. So it makes a uniform. So I'm getting on board with the multiple cut intramedullary nailing option primarily for that reason. And I think it'll become obvious and also consistent with the presentation that you had given with regards to really identifying where the deformity is. So to do a single opening, closing wedge, or oblique osteotomy, you can do anything, but I think it would be very unpredictable for a problem like this.
Yeah.
Rafi, the alternative that I've done in the past is Sofield. So multiple osteotomies at multiple levels, usually closing wedge, and that is straightforward, and with the intramedullary nail reestablishes your alignment. But the clamshell, I think, is a little bit more efficient. And diaphyseal osteotomies, simple diaphyseal osteotomies, you're at risk for having issues with healing. So.
And just one comment, Rafi, I like that idea of the Sofield too, but I'm just looking at her canal. It looks pretty narrow in that mid to proximal part, and I've had to abort a few times trying to get mobility of the nail through those segments in that situation. And then if I could just jump back, one thing, Rafi, I know you want to just move through the technical parts, but just assuming that you said just assuming the metabolic parameters are normal. These rickets patients are super tricky and they have all these deformities. So the one consideration for sure in this situation, vitamin D resistant, is to make sure their phosphates in a good range, if not supplemented. And then, so you got to work with whoever does that if it's not you. And then the other thing is with the rickets patients and the multi-deformities is discussions about sequencing for the patient who would love to have it all done at one time or more than one done at one time. So sequencing discussions are probably pretty relevant here in terms of figuring out a way to do maybe more than one to save them some anesthesia, but not to completely disable them.
Yeah, those are great points. I would think that you need to work with endocrinology to make sure that you as orthopedists, we're just not experts in that. The canal, if you look at the literature for Sofield osteotomies, there are some modifications of it that are percutaneous, but still, when you look at those examples, the case examples of the severe bowing, they do use small caliber nails, and some of those studies are historical, but even doing them now, they still use very, very small caliber nails, and some of them aren't even locked. So, so we have those. The options have been discussed, but I think the length of the deformity kind of lends itself to what we've heard here is trying to do a clamshell osteotomy for this. So kind of thinking about where you're going to put your proximal and distal ends of the clamshell is important. You want to span the entire defect. So let's hear from Matt Graves if he's around. About the length of this osteotomy.
Yeah, so there was a really good question that was asked in our diaphyseal module about what are the limitations of the clamshell osteotomy. And I think there are limitations in terms of contraindications, meaning when you shouldn't do it if you don't have access to a proximal or distal canal, or you don't have access to the actual zone of deformity itself. It makes it impossible to do. But there's also a limitation to the correction that can be achieved with the clamshell osteotomy. And I've made this mistake before on a case that was a severe deformity similar to this. And so you have to be careful and make sure that each of the transverse osteotomies will allow you to get a nail into the anatomic axis of that segment. Meaning if you were to take a bowing deformity like this and you were to make transverse osteotomies really close together, I'd be very concerned that you would struggle to get the nail into the correct location into the proximal and distal segment. So one of the things I do in preoperative planning when I'm doing these is I try to find the edge of the deformity proximally and distally when I'm trying to decide where those transverse osteotomies have to be. And sometimes you make compromises, meaning you want to keep a reasonable length of the proximal and distal segment. And so you make a compromise and make one of the transverse osteotomies not truly in a straight portion of the bone, but at least it's far enough towards it such that you can get the nail to be in the anatomic axis in the correct position.
Yeah. So you make a great point. You can see on she had a pretty significant sagittal plane deformity, which has been mostly corrected, but you see how close the nail is on the anterior cortex. And I think it's probably speaking to that point you made. When you look at the overall correction, they did a nice job. If you look at the preoperative, they weren't able to get the nail as long as they wanted. And that is going to be the case with severe bowing deformities. So it's a sort of a balance for this. So the patient gets 1 year follow-up and is doing well. And to speak to Mark's or somebody's comment about making sure you discuss with the patient their staging, so you're not you're meeting their expectations about not doing them all at the same time. She's happy with her right leg and doesn't want to do anything to the right tibia. So, but she does want to do something to the left side. So let's talk just quickly about the femur. If we maybe Raul, if you're around, what would you do differently about the femur? Would you do the same thing, understanding that the deformity is a little bit bigger in both the coronal and sagittal planes?
Yeah, you know, that's where I think two separate osteotomies might be the case. You couldn't get the straight nail up to the proximal femur on the first side. And I was just going to ask Matt, have you ever done 2 clamshell osteotomies in the same femur? Or do you do like a clamshell with a Schofield, like another osteotomy higher up?
Yeah, so in the past, when I've had large deformities like this, I've just made a much larger approach to the segment. And that's the compromise of making a single clamshell for this, is you have to have a long lateral approach if you're going to do that. An alternative would be what you describe, is to consider making 2 clams or a separate osteotomy proximally that wasn't as complex or wasn't as long, I guess, as the clam, in order to be able to get into the correct position in that segment. I think to correct this femur completely, the osteotomies would have been either you would have needed another like you described, or you would have needed to be closer to the edges of the bone in order to do it. So yeah,
you could still take that nail out, do a proximal osteotomy, and put a longer nail antegrade, and get your varus alignment straightened out. But you'd have to probably do an opening wedge if you didn't do a clamshell.
yeah.
Like you said.
Yeah.
So the left side is quite a bit more deformed than the right, and Sean had talked to us about if you try to get one angulation or one cora, if you look at the proximal in the femur, your cora is going to be outside of the bone, which is it tells you either you have a multifocal deformity or a significant translation, and in this case, multifocal. Same thing with the tibia. Let's just look at what they did for the femur, because I think based on how she did with the first side, they decided to make the osteotomy bigger, longer, and they ended up with the nail going coast to coast, basically distal to proximal the whole way. And that speaks to how Matt discussed, you got to make the segment long enough to be able to get your correction. And that's, it looks like what they did. Is anybody concerned with the wide displacement of that clamshell in the center?
No.
No.
No. So as long as you have reamings in the transverse portions of this, and you leave that comminuted segment just like a transverse or a comminuted femur in acute trauma.
It's what we can't see that matters most, Rafi. I mean, really, it's the technique, I think, in the photo that's nice, showing that, you try not to do a really stripping dissection there. You try to leave attachments anteriorly and posteriorly immediately to that segment. And
yeah, you can see that. Yeah, they did leave you can see, well, here there's a little bit of stripping, but they've got a lot of soft tissue still attached to the segments before they finished.
There is one other comment on the side that was fixed first that could have helped. If they'd used a blocking screw or something to help get the nail more centered in the distal piece, I think you could have corrected the varus on that one, even with the one that we had there.
Yeah. So now back to Sean's comment again about a single cora, you saw initially that there were multiple deformities, even to the tibia here and here, and they resolved it into a single one, which is within the bone. So that tells you that it can be corrected with now a different type of osteotomy. So she does have torsion. That doesn't mean you can't correct that with a single cut. So in order to learn how to do that, you're going to need to stay tuned and come back with us for week 9 tibial diaphyseal deformities. Between now and then, we'll have some really great cases in the distal femur and proximal tibia to go over. So with that, let's head over to our discussion cases, and then we'll do a little wrap up at the end and see what other questions arise. So sounds like we're back in the main room now. Can people hear me?
Yes.
Yes, we're good.
Yep.
Go ahead, Rafi.
Go.
All right, so we're gonna say thanks to all the small groups. From these cases, hopefully you realize that we can do these corrections from a variety of different approaches in osteotomies. Bone transport and lengthening procedures can be achieved, but require some pretty significant vigilance to minimize your complications, and you're gonna get them. Clamshell is very versatile with a good margin of error without having to do a lot of math. That hurts to think about some of that math sometimes, but that does give you a bigger margin for those. But those techniques require so much planning. So coming up on Thursday is another discussion group, but the difference here is, like we did 2 weeks ago, is we want your cases. We want you to send us your cases so that we can discuss those. And what we really want are cases that you have good imaging, you have some clinical photos that may reveal the deformity well, and then your thoughts of either what you need to learn from us on how to proceed, or if they're some completed cases. And this is where you'll send them, webmaster, with these sort of items in your cases. But that doesn't register you specifically for the meeting, so you also have to register. So for those of you interested in coming next week to the Thursday, I highly encourage that, so you can see each other's cases as you go to this same place that you've been going before. You can review all the previous lectures that we've done, register for the next event, and all the future ones. We have periarticular knee, which is going to include distal femur and proximal tibia osteotomies. So that's it's going to be really interesting, unusual cases in some instances. We're going to have this Zoom available for you in 24 hours to review if you like. It may not be the room that you were in that you see, but we recorded all the rooms. They'll be available a little bit after that on the YouTube AO Trauma North America under the playlist Osteotomy course. So we do have, Angel, do we have a question for everybody to answer a poll?
Yes.
All right, so with that, I'm going to say thanks, and we'll have you look at this question. How would you prefer the case discussions to be run next time? Small breakouts, or with the expert panel as we did today? And with that, we'll say thank you. Tune back in for the next 4 weeks of the AO Osteotomy Weekly course.